I want to thank the organizing committee for the invitation. And let me share what we're doing in San Juan, Puerto Rico lately. Let me check here. These are my disclosures. And we know that endometriosis is, for me, underdiagnosed, and the prevalence is more. What we have seen lately, I heard one of the speakers says as it could be up to 20%, and I think that could be correct, because I think we are misdiagnosing or not doing the correct diagnosis. And most of the patients delay almost to 10 years to be diagnosed, and the average age of this patient is 28 years old when they, for the first time, have a diagnosis of endometriosis. We have many theories that we have debating today, the retrograde menstruation, Hoxha genes, and this is a very good paper that was presented in December 2018. Dan Martin is here, so it's a very, very good paper, and I think that it explains a lot of what we did not understand for many, many years. And at the end of the presentation, I will talk just a little bit more about this one. The most frequent presentation of the patients, is dysmenorrhea, dyspareunia, infertility, and all things that all of you know most. But most of the patients that we see at the office, the young patients, they present with dysmenorrhea. That is the most common presentation, and the pediatric doesn't see it. Pediatricians doesn't see that the patient have something that is not normal and never refers the patient. And sometimes they see 5 to 10 doctors before somebody think, oh, this could be endometriosis. We can help this patient. And yes, we know, Dr. David Radwan, that laparoscopy is the best things to, and the definite diagnosis, having pathology and identify that the patient have glandular tissue and stromal tissue. But sometimes if we go directly to do the laparoscopy, probably we're dealing with some superficial endometriosis, or we can miss something and we're really working with the tip of the iceberg because we didn't do a correct preoperative evaluation, or we didn't really do a good workup to this patient. And in those days when, or these incredible doctors, Dr. Redwine, Dr. Dan Martin, Harry Rich, C.Y. Liu, Charles Koh, they were doing those surgeries without the aids of sonography. That is what we use right now. It was very, very impressive and very brave from them to do that without any help that we have now. And as we know, there's many other things that cause pain in the pelvic area. That I told my patients, everything that glitters is not gold. You can have other conditions that could be either causing the pain or it could be concomitant with the endometriosis pain. So we have to identify not only that this patient could have endometriosis, but we have to identify that she could have another condition that will be also giving the pain. And when I explain to my patients, I give like a little lectures. I spend probably like 1 hour or more for $15. That's what we get paid in Puerto Rico to see a patient. But you have to do the work. It doesn't matter how much they pay. That patient could be my sister, my wife, my daughter. So you have to really try to diagnose and help the patient. So I explain to my patient, you have superficial endometriosis, you have deep endometriosis, you can have endometriosis in the ovary, on the bladder, you can have adenomyomas. And I give like a little lecture to all these patients so they could understand, because if they understand, they could follow all the treatment very well. And to talk a little bit about what we do and what it's the most important thing now to diagnose this deep endometriosis, we know about sonography. This is a pearl. Everything that comes in medicine usually have come from the war, and sonography was also that. It came from, in the First World War, they used the sonars to identify the submarines. So many of the equipment that we use today come from the war. So this is the most important paper that really, I think, changed everything. When Mauricio Abreu in 2007 presented that with a simple endovaginal sonogram with 3 enemas at the office, He can diagnose deep endometriosis in the retrocervical area and in the bowel. And this is when he compared this study with MRI and looked at results that are completely different. We don't have to go for an MRI to do the diagnosis of deep endometriosis. And this is another study that was done for compare all different, it was like a Cochrane review with all in different languages, just to confirm that endometriosis, deep endometriosis is diagnosed with transvaginal sonography. And you can see in the sonogram, when you do it at the office, you can see all the layers. Let me check where's the, all the layers of the bowel, and you can identify if the patient has a lesion, it's only superficial in the serosa, or you can identify the distance from the anal verge, so we can predict if we're going to have an ileostomy or not, or a colostomy on these patients, just before we go to the surgery. We can predict if we're going to do a discoid resection, shaving of the lesion, or we're going to do a segmental resection, because we know the circumference of the bowel that is involved with endometriosis lesion. So it's very important for us to know that prior to go to the OR. We can identify the septovaginal rectum perfectly and identify the lesions there. That's why when I talk in the morning a little bit about if I don't find the lesion, I call my sonographist, come back to the OR, look for that lesion, because I'm going to take it out. I do only one surgery, and it's a complete surgery. We can see lesions on the bladder. And as we know, ACOG says that we have to use a variety of medical options first before we start to think in doing surgery. And ASRM said that endometriosis is best viewed as a medical disease with a surgical condition, with a surgical backup. But we didn't have any data to sustain that. So we decided in our office to see if we can do something to confirm that that was true. So in 2011 at the World Congress of Endometriosis, we present the target organ sonography score, that it's a preoperative evaluation with sonography. It was a prospective study at that time. And we do a score that we compare with the ASRM laparoscopy staging. And these were the results. We have a very good correlation, not only that we can find the lesions and identify them and put on a mapping, but also we can predict the complexity of the surgery. So if I tell the doctor that referred the patient to us, you cannot do this surgery, it's going to be very complicated, and you're going to do the laparoscopy, and you're going to go away, refer the patient to have the complete surgery with us, and then we review the patient back. So we decide to do, does diagnostic laparoscopy is really necessary as the first line of evaluation? It's a prospective study. The chief complaint was dysmenorrhea, dyspareunia. This patient have 10 out of 10 in the VAS score. Some of them you asked them and they said, I have 20 out of 10. And you know that you can see that easily in your office. They have to be absent from school or from work. They need narcotic for pains. They visit the emergency room, and their goal is to resolve the problem, not to become pregnant. We do the sonogram first to rule out any deep endometriosis and do a complete examination of the patient. And this is the algorithm that we developed. We do the sonogram. If the sonogram is negative, we evaluate patient for IC, for pudendal nerve neuralgias, constipation, for IBS, and then we put the patient in the protocol. If we identify any other condition, we treat the other condition either concomitant, or if it's the one that is causing the pain, we put the patient in the protocol. If the sonogram is positive for deep endometriosis, but it's not causing harm to the patient, we go directly to the protocol. But if the patient needs surgery, we refer the patient to the division of the office to do the surgery. The protocol is put the patient without menses, either with oral contraceptive without the placebo, IUD progesterones, vaginal rings, or progesterone pills. These are the patients. We have right now 121 patients. We have to stop a little bit because, you know, when Maria hit Puerto Rico, my office was closed like around 6 months, so we have to stop recruiting patients. But so far we have 121 patients. 5 are pending to do the sonogram evaluation. Sorry. 44 are pending to be reevaluated after they start the treatment. 72 have been evaluated without menses with the treatment that we have here. This is the score of the TOS. Most of them have 0, so they don't have anything of deep endometriosis, no bowel lesions, nothing. This other diagnosis that found with the patient, adenomyosis, and IC, IBS and constipation, IBS and constipation, IC. Adenomyosis, some of them had already laparoscopy, but they don't find anything. But they still have the pain every month. This is the type of treatment that we gave. Most of them are in oral contraceptive without the placebo. And this is the result now that we have so far. 86% of those 72 patients never been absent again to school, never been in emergency room, never used narcotic. Only 40% have some breakthrough bleeding or have minimal pain during the cycle, and they don't need not even a Tylenol to resolve that problem. We do evaluation of the patients every 3 months, times 2, and we repeat the sonogram in 6 months. We have direct communication with all these patients. They all have my cellular number, my personal cellular number. So if they have any doubt or any complication with the medication they're using, they have to call me. It doesn't matter the time. I think that the compliance depends on the understanding of the patient. If they understand what they're doing, they're going to follow the instructions, and if they have any doubt, they're going to call you, and the results are the one that you have seen here. So the take-home message that I want to give all of you is that still the sonogram is the best to diagnose deep endometriosis. We have to rule out other conditions that could be concomitant with endometriosis or that are the cause of the pain. Diagnostic laparoscopy should not be the first line of treatment. And if you're going to do a surgery, you don't go blind. Now we have the sonogram that you can do a map and you can identify the lesions and you can help this patient much better than we used to do it before. It's a teamwork. I do the surgery with colorectal surgeon or a GYN onco and also with the urologist. And if we do have to have a surgery for the patient, we only have one surgery. That's our goal for them. In the future, I think that epigenetic, it's a very good topic. I think what I explain to my patients is that it's like if a composer writes a song, he wants to be played in one form, so epigenetic would change the ways some people will play the song, and we want the song is playing with endometrium and not endometriosis. So I think that if we can work in the expression of the genes, probably we can have some cure in the future that will help the patients. This is my family that been helping me to go through all the work every year, taking the message of endometriosis. And this is what I have for you we're doing in Puerto Rico. Thank you so much.